Welcome along to the deep dive. Our aim here is always to help you grab that essential knowledge quickly, right from the material you give us. Today, we're focusing specifically for you on Patau syndrome, that's trisomy 13, based on these revision notes you've shared.
Exactly.
And the goal is pretty straightforward. Give you a really clear, high-yield overview for your revision, without getting lost in the weeds.
That's the plan.
So we'll sort of walk through it all: definition, causes, risks, how it affects the body, what else it might look like, who gets it, how it presents, diagnosis, management, outlook, the whole lot.
Sounds good. Let's get started.
Okay, so definition first. What exactly is Patau syndrome?
Right. So Patau syndrome, basically, it's a rare genetic disorder. The core issue, the absolute key, is having an extra copy of chromosome 13.
Trisomy 13.
Trisomy 13, exactly. And that extra bit of genetic information, well, it causes some major problems. We see severe developmental disabilities and multiple physical issues present right from birth, those congenital anomalies.
And how common is it? The notes mentioned a range.
Yeah, it's estimated around 1 in every 5,000 to maybe 1 in 12,000 live births. So quite rare.
Okay.
And unfortunately, it does carry a high mortality rate, and there's also that link we need to remember with advanced parental age.
Got it. So extra chromosome 13, you mentioned it's genetic, but thinking about the cause, the etiology for revision, where does that extra chromosome come from? Is it something parents pass down?
Good question, and really crucial for understanding it. Overwhelmingly, in almost all cases, Patau syndrome isn't inherited.
Oh, okay.
Yeah, it's usually down to a random mistake, an error that happens when the reproductive cells, the egg or the sperm, are forming, or sometimes it happens very, very early on, just after fertilization.
It's sort of spontaneous event then.
Exactly. Sporadic is the word we often use. So while, your notes might touch on family history as something to consider in counseling, the syndrome itself usually just happens out of the blue.
Okay, sporadically.
Yeah.
Good term for revision. So if it's mostly random, are there things that make it more likely to happen? Any known risk factors?
The main one, the most clearly established risk factor, is definitely advanced maternal age.
Right.
We see that the older the mother is at conception, the slightly higher the chance of trisomy 13.
Okay.
Your notes also flag up some other potential factors, things like maybe exposure to certain environmental things or perhaps medications during pregnancy. And as we touched on, having had a previous affected pregnancy.
But that would usually trigger genetic testing for the parents, right?
Precisely. To understand that specific family's recurrence risk. But for general revision, remember, advanced maternal age is the big one, even though the overall risk for Patau still stays relatively low compared to some other trisomies.
Okay, maternal age is key. So let's dig into the why, pathophysiology. What's that extra chromosome 13 actually doing to mess up development?
Well, fundamentally, it throws a spanner in the works of normal fetal development. That extra chromosome means you have extra copies of certain genes, which means an overproduction and overexpression of the proteins those genes code for. You could sort of think of it like having too much of certain ingredients in a recipe. It disrupts the whole process.
The gene dosage effect.
Exactly. The gene dosage effect. That's the term. It upsets the normal formation of organs, tissues, the whole developmental plan, really. This leads to that cascade of effects, the multiple organ issues, the developmental problems.
Okay.
The precise sort of molecular steps involved are still being figured out in detail, but the core problem is that genetic imbalance from the extra chromosome 13.
Gene dosage effect disrupting development. Got it. Now, thinking clinically, maybe for an exam scenario, if a baby presents with some of these features, are there other conditions that might be on the differential diagnosis list, things that look similar initially?
Oh, absolutely. That's really important. You always have to consider other possibilities. Edwards syndrome, which is trisomy 18, is a key one.
Okay, Edwards, trisomy 18.
Yes. It also presents with multiple congenital anomalies and developmental delay, so there's overlap. Then there are other, much rarer genetic syndromes that might share some features.
And the notes mentioned pseudotrisomy 13.
Right. That term describes cases where a baby might have physical signs suggesting trisomy 13, but actually the underlying genetic cause isn't an extra chromosome 13. It could be something else entirely.
I see.
Which really just highlights why getting that definitive genetic test, like karyotyping, is so vital. You need to confirm what's actually going on genetically. But for revision, yeah, Edwards, trisomy 18 is probably the main differential to keep in mind.
Edwards, okay. So back to Patau itself. Epidemiology, How common is it, say, here in the UK? Can we get more specific than the earlier range?
Yeah, for the UK, the estimates tend to cluster around 1 in 10,000 to maybe 1 in 16,000 live births,
Okay.
which fits within that broader global picture. For trisomy 13, generally quoted as somewhere between 1 in 5,000 and 1 inch, maybe 29,000 live births worldwide. There's some variation in reporting.
And it's linked to rising maternal age trends.
Yes, that correlation is consistently observed. And just to put it in context, thinking about the common autosomal trisomies, the ones involving non-sex chromosomes.
Downs, Edwards.
Exactly. Trisomy 21, Down syndrome is the most common.
Hmm?
Then comes trisomy 18, Edwards syndrome. And then trisomy 13, Patau syndrome, is the third most common in newborns.
Okay, so 21, 18, 13, that's a helpful order to remember.
Yep.
Right, let's move on to what you'd actually see. The clinical features. What are the key signs and symptoms associated with Patau syndrome?
Okay, the features are typically quite extensive, and they can vary a bit from baby to baby, but there are definitely some characteristic things to look out for.
Like what?
Well, severe intellectual disability is universal, unfortunately. Then facial abnormalities are very common, particularly a cleft lip or a cleft palate, or sometimes both. Congenital heart defects are almost always present. Think things like holes between the heart chambers, atrial septal defects, ASDs, or ventricular septal defects, VSDs. Also, a patent ductus arteriosus, or PDA, where a fetal blood vessel doesn't close as it should. Sometimes even dextrocardia, where the heart's positioned on the right side of the chest.
Wow, okay.
Another really classic sign is polydactyly extra fingers or toes.
Yes, I remember reading that.
Yeah, it's quite distinctive. And then there's a whole range of other potential malformations, things like holoprosencephaly, which is a severe brain abnormality where the brain doesn't divide properly into two hemispheres.
Okay.
Also, neural tube defects like spina bifida, microcephaly, a small head size, sometimes specific scalp defects called cutis aplasia, ear malformations, which often go along with deafness, little red birthmarks called capillary hemangiomas, and problems with the gut or the urinary and genital systems.
It really is a multi-system condition then.
Absolutely. The key takeaway for revision is the sheer breadth of potential issues. Multiple organ systems are usually affected.
Okay, a broad range of severe features. So if a clinician suspects Patau based on these signs, how do they confirm it? What investigations are done?
Confirmation absolutely requires genetic testing. That's the definitive step.
Karyotyping.
Karyotyping is the traditional method, yes. It lets you literally see the chromosomes under a microscope and count them, revealing the extra chromosome 13. Chromosomal microarray analysis is another, often more detailed, genetic test that can also diagnose it.
And can this be done before birth?
Yes, definitely. Prenatal diagnosis is possible using procedures like amniocentesis, where you test the amniotic fluid, or chorionic villus sampling, CVS, where you test a tiny piece of the placenta. Both give you fetal cells for that genetic analysis.
Okay.
After birth, the diagnosis is usually suspected based on the clinical features we just discussed, and then confirmed with a DNA analysis from a blood sample. Sometimes doctors might also notice persistently high levels of fetal hemoglobin in the baby's blood, which can be another clue.
And what about checking the specific organ problems?
Right, depending on what abnormalities are found, you do targeted investigations. So an echocardiogram, an echo, is essential to assess the heart defects. Skeletal x-rays might be needed if there are limb abnormalities like polydactyly, brain imaging like an MRI or ultrasound if holoprosencephaly is suspected, and so on.
So genetic testing is the cornerstone for diagnosis, plus specific tests for the anomalies.
Okay.
Once it's confirmed, what's the approach to management?
Management is really centered around supportive care. Given how complex the condition is, the focus is on managing the symptoms the baby has and providing comfort.
It sounds like it would need a big team.
Oh, absolutely. A multidisciplinary team is crucial. You'd have pediatricians, geneticists, cardiologists, surgeons, nurses, therapists, all working together with the family.
Is surgery ever an option for things like the heart defects?
It can be, yes, for certain severe issues like some heart defects or maybe a cleft palate repair. However, any decision about surgery is incredibly complex. It has to be weighed very carefully, considering the baby's overall condition and the very poor long-term prognosis associated with Patau syndrome. These are really difficult discussions with the family.
I can imagine. What about other support?
Essential. Families need access to a whole network of support. Social services, physiotherapy to help with movement and positioning, feeding support, and crucially, genetic counseling.
Why is genetic counseling so important here?
Well, it helps the parents understand the diagnosis, what it means for their child, and importantly, what it means for future pregnancies. It clarifies the risk of it happening again.
Okay.
And ongoing emotional support and counseling for the parents is just vital throughout. It's also generally recommended that the parents themselves have chromosomal analysis done,
Why is that?
mostly to check if, very rarely, one parent carries a balanced translocation involving chromosome 13. That wouldn't affect the parent, but it could increase the risk of having a child with an unbalanced arrangement, like trisomy 13, in future pregnancies. It also helps clarify risks for other family members.
I see. And you mentioned screening during pregnancy earlier. Can we just quickly recap that?
Sure. So, routine pregnancy screening usually offer between 10 and 14 weeks the combined test screens for Patau, trisomy 13, alongside Downs, trisomy 21, and Edwards, trisomy 18.
That's the blood test and the ultrasound.
Exactly. Blood tests measuring certain hormones combined with an ultrasound scan. The scan specifically looks at the neutral translucency, that fluid-filled space at the back of the baby's neck,
Right.
which tends to be increased in these trisomies. The scan might also pick up early signs of heart problems or other major anomalies.
And later ultrasounds.
Later scans can also show suggestive features, things like the holoprosencephaly, the polydactyly we mentioned, or maybe the baby isn't growing properly.
How effective is that first trimester screening?
It's pretty good. The combined test detects over 90% of trisomy 13 cases. If someone misses that window, there's also second trimester screening available.
But screening just gives a risk score, doesn't it? Not a diagnosis.
Precisely. That's a critical point. Screening identifies babies at higher risk. A definitive diagnosis before birth requires one of those invasive tests, amniocentesis, or CVS, to get fetal cells for chromosomal analysis.
Okay. And who typically gets offered the diagnostic test?
Well, women over 35 might be offered diagnostic testing directly because of the age link. And anyone who gets a high-risk result from the screening test would then be offered diagnostic testing to confirm or rule out the condition.
Understood. One practical point, feeding. You mentioned issues there.
Yes, feeding can be a major challenge for babies with Patau syndrome, often due to the facial clefts, poor muscle tone, or neurological issues. Sometimes feeding tubes are needed, either a nasogastric tube down the nose or a gastroscopy tube directly into the stomach. But again, any intervention like this involves very careful discussion about goals of care, always respecting the parent's wishes.
This is a lot to take in for revision. Now, the difficult part, the prognosis. What is the typical outlook?
Unfortunately, as we've hinted, the prognosis for Patau syndrome is generally very poor. Most babies born with full trisomy 13 don't survive for long. The median survival time, the point at which half have passed away, is very short, only about 2.5 days.
Yes.
Yeah. Roughly half, maybe a bit more, will live longer than a week. And maybe around 5 to 10% might survive past their first birthday.
But with significant challenges.
Yes. Those who do survive longer invariably have profound intellectual and physical disabilities. There is a small caveat for something called trisomy 13 mosaicism.
Where only some cells have the extra chromosome.
Exactly. In mosaicism, the outcomes can be more variable, potentially less severe, and survival might be longer, but it's still a very serious condition.
Yeah.
But for the standard, full trisomy 13, the outlook is stark.
Understood. And lastly, just to summarize the main health problems, the complications these children face.
The major complications really stem from all those features we discussed. So severe intellectual disability and developmental delays are universal. Congenital heart defects are a major source of morbidity and mortality.
Right.
Then you have the potential for kidney problems, eye abnormalities, hearing loss linked to the ear malformations, and issues related to all the other potential organ malformations. Feeding difficulties, as we said, are common and can lead to failure to thrive. Seizures can also occur.
So it's a constellation of serious issues.
It really is. The impact of that extra chromosome is felt across nearly every system in the body, leading to this complex picture of medical challenges.
Okay, well, that's been an incredibly thorough run-through of Patau syndrome.
Yeah.
Definitely hitting those key revision points.
Hopefully useful.
Absolutely. So just to quickly recap for you listening, Patau syndrome is trisomy 13. Remember, it's usually sporadic, linked to maternal age. Think multiple severe congenital anomalies, clefts, heart defects, polydactyly, brain issues. Diagnosis is confirmed by genetic testing. Management is supportive, multidisciplinary, and sadly, the prognosis is generally poor with significant complications.
That covers the main points.
Yeah. So if this deep dive has helped your revision and you're looking for more resources, maybe practice questions or other summaries, definitely check out passmsra.com.
And there's also freemsra.com for free resources, too.
Great suggestions. Thanks so much for joining us for this deep dive.
My pleasure.